Okay, we're back. This time for same kind of stuff. Phys and histo. This time maybe some nutrition and maybe some anatomy. Okay. Okay, let's get started. So again, why does the air move? Well, part of it's due to Ohm's law. We talked about Ohm's law previously, very long ago. It's when something moves proportional to the driving force and inversely proportional to the resistance to movement. The driving force is pressure. So if air is moving from outside the body into the lungs, then the pressure inside the lungs must be lower than the outside of the lungs pressure. Or else how's the air going to get there? It's all a gradient. Okay. Excuse me, that was kind of gross. Okay, so anyway, so there's things intrathoracically that affect the pressure. There's intrathoracic pressures. There's the pleural space. It has a slightly negative pressure, which holds the lungs partially expanded. And if it's, and it is filled with fluid that transmits pressure signals perfectly. So this is why if you get a hole in the pleural space, it can be very bad for respiration, because then that slightly negative pressure is not there, and so you have to work much harder to move air. Okay, and then the thoracic cavity is formed by the diaphragm, and it's in a dome shape. Contraction flattens the dome, and that creates negative pressure in the thorax. This is how breathing works. Inspiration, expiration, those are other words for inhalation and exhalation. Okay, and then when there's a more negative pleural pressure, your lungs expand. So tissues within the lung stretch, the air spaces enlarge, and the pressure in the air spaces drops. And as tissues and ribcage reach their stretch limits, less tissue stretch occurs, so less air is moved per force applied. Okay, and then for exhalation, relaxing the muscles around the lungs results in recoil and increased pressure on lung tissue. So the air spaces shrink, pressure increases, and then air moves out of the lungs. And in most species, this is passive. Horses actually have active exhalation. The breath, can't remember what FRC means. FRC is functional residual capacity. So let me go back down here to where I was. Yeah, horses have active exhalation, so breath around functional residual capacity instead of from and back to functional residual capacity. I don't know if that's supposed to be breath or breathe. Anyway, So how can we increase capacity? Like if we're exercising, if we need to breathe more, how do we do that? Well, there's two ways. We either increase minute ventilation, which means you either breathe faster or deeper, or you increase cardiac output. And unless there's an increase in ventilation, the improvement in blood gases is limited by this. There's limits to this, of course. It costs more energy, and your body can only do it so much before it breaks, basically. But what happens once the air is in the alveoli? Well, it exchanges O2 and CO2 with pulmonary blood, and it does not use energy to do this. It uses a concentration gradient. High alveolar O2 to low blood O2. High blood CO2 to low alveolar CO2. Okay, and then there's gas laws, like Dalton's law. The total pressure of a gas is the sum of the partial pressures of its components. For example, if air is at a pressure of 1 atmosphere and is composed of 20% O2 and 80% nitrogen, or N2, then the pressure of O2 in the air is 0.2 atmospheres of pressure. Then there's Henry's law. The amount of gas dissolved in a liquid is proportional to the partial pressure of the gas and the solubility of the gas. Okay, and then the pulmonary diffusion path. O2 must travel across alveolar epithelium, interstitium, endothelium, plasma, and red blood cell membranes to bind to hemoglobin. Because O2 is poorly soluble, it needs a carrier protein, which hemoglobin is. And this is important because that's usually enough time, but during strenuous exercise, it might not be enough time, and you might start to pass out and stuff like that. Okay, so normal arterial blood contains about 20 milliliters of oxygen per deciliter of blood. Again, solubility of O2 in plasma is low. So only about 1.5% of blood oxygen content of arterial blood is in the dissolved form. Not much. The rest is bound to hemoglobin. 1 molecule of hemoglobin can carry up to 4 molecules of O2. And that is the hemoglobin. The heme group that is contained in the hemoglobin is very, very often ferrous iron, which is 2+ iron, not ferric iron, which is 3+. Methemoglobin is ferric iron. Methemoglobin is not common. Okay. Moving on. That's it. All right. We're done with that. Now we have, looks like, nutrition and anatomy. And if I'm not mistaken, this nutrition is part of the stuff I needed to know for the previous exam. So there's not much, I don't know, this is kind of important for y'all. So nutrient content of food. There's as-fed basis, dry matter basis, and then there's feeding on an energy basis. So you can always determine nutrient levels by looking at the guaranteed analysis on the pet food label. It's usually on the back of the bag. And it'll say how many calories are in, this many kilograms of the feed or whatever. But it differs per food, of course. Like there's dry food, kibble, which contains very little moisture, but does contain still some moisture. Then there's canned food, which contains much more moisture. And then there's things like soups or, toppers contain almost all moisture. So you're basically just paying for water at that point. Okay, practice examples. But that's good to know because, for example, a can of wet food might be a whole meal for an animal, whereas just a scoop or a cup or half a cup of dry food would be enough. Now the can is like 16 ounces, which is like 4 cups, I think. I'm not too sure on that. Don't quote me on that, but my point is that it can vary. Hi. How you doing? Okay. Again, it varies per food. It varies depending on what the food is. But something to know is that if you're feeding as fed versus dry matter basis, the dry matter basis will always contain more nutrients, because it's just more concentrated than the as fed version of that same feed. So, for example, if I I don't know, if I get a can of wet food, like okay, just think about this. If you get grapes, if you get like a cup of grapes, and then you dehydrate them into raisins, they now weigh less, but they still have the same amount of nutrients that they had. And so per gram of weight, they have more nutrients. Does that make sense? So that's why dry matter is more concentrated energy. Okay, moving on. And there's also metabolizable energy. Not all energy is used by the body. There's fecal energy, there's urinary energy, there's waste, heat. The body does this. And it's just natural. Okay, that's it for nutrition. And these are going quick. Anatomy, let's see here. Ooh, the pelvic limb. Okay, so the hip, these are the bones. Okay, this is the hip, which is also called the os coxae. It contains the ilium, the ischium, and the pubis. Then there's the thigh, which just contains the femur. Then there's the crus, which contains the tibia and the fibula. Then there's the pes, which is the hind paw, contains the tarsus, metatarsus, and digits, which contain the tarsals, the metatarsals, and the phalanges, respectively. Okay, so the pelvic girdle contains the ilium, ischium, acetabular bone, and the pubis. Then the femur, or the thigh, has the patella, etc. Okay. Then there's the pes, which is another word for the hind paw. The foot, basically. The foot itself. It contains tarsals: the talus, the calcaneus, the central tarsal, and then tarsal bones 1 through 4 to make 7 in total. Okay, so then there's the muscles of the rump. Some of these are pretty important. Not all of them are, though. But the ones I'm going over are the superficial gluteal muscle, the middle gluteal muscle, and the deep gluteal muscle. What they do is they extend the hip and they abduct the limb. Not adduct, but abduct. Okay, then there's the cranial muscles of the thigh. These are the sartorius, the quadriceps, and the tensor fascia lata. These flex the hip and they extend the stifle. Then there's the cranial muscles of the thigh. These are the sartorius, the quadriceps, and the tensor fascia lata. I just said that. This is a different angle. Okay, then there's the medial muscles of the thigh, the gracilis, the adductor, and the pectineus. These are adductors, and they have a little bit more function than that, but that's the general gist of it. Then there's the caudal muscles of the thigh, the biceps femoris, the semimembranosus, and the semitendinosus. These flex and extend. They flex or extend the stifle, and they extend the hip. Then there's the cranial muscles of the crus, the cranial tibial muscle, the fibularis longus muscle, the long digital extensor muscle, the lateral digital extensor muscle, and the fibularis brevis. These flex the hock and extend the digits. Then there's the caudal muscles of the crus, the popliteus muscle, the gastrocnemius, the superficial digital flexor, and the deep digital flexor. These extend the hock and they flex the digits. In a cat, there's a couple unique things to know. The cat has a gluteofemoralis muscle, which is caudovertical, which is caudally vertical to the fascia lata. What this muscle does is it helps them swish their tail. Then there's the soleus muscle. This is found near the fibula to the tuber calcanei, and this extends the tarsus. Those are two muscles that are different from cat to dog. Okay, so if you're trying to get a bone marrow aspirate or a biopsy, you most commonly use the wing of the ilium for core biopsies and the trochanter fossa of the proximal femur for aspiration biopsies. And that is in small dogs and cats, sorry. In large dogs, you may try a dorsal approach to the iliac crest for aspiration and core biopsies. In all small animals, the proximal humerus is also an excellent site for both aspiration and core biopsies. There's many reasons why you'd want to do these, though. One reason is non-regenerative anemia. Another is persistent neutropenia or thrombocytopenia. And another one is neoplasia and or infectious organisms. Okay, then there are joints on the limb of the pelvic limb. There's the sacroiliac joint. This is where the sacrum meets the ilium. Then there's the hip joint, where the femur meets the hip bone, or the os coxae. And then there's the stifle, which is where the femur meets the tibia. Then there's the tarsocrural joint. That's where the tibia meets the tarsals. Then there's the intertarsal joints between the tarsals. Then there's the tarsometatarsal joints, which is where the tarsals meet the metatarsals. Then there's the metatarsophalangeal joints, where the metatarsals meet the phalanges. Then there's the interphalangeal joints in between the phalanges. Pelvic fractures account for 20 to 25% of the fractures seen in veterinary practice, and most of them involve at least 2 fractures, and many involve all 3 bones of the pelvis. Usually they're handled adequately without surgery because they're so surrounded by muscle and other tissues. But sometimes they do need a surgery, or not need, but it would very much help. Hip dysplasia is a common problem with the coxofemoral joint, or the hip joint. This is basically where the femur head is this is either where the femur head is deformed or where there's a shallow hip socket. So a shallow acetabulum, basically. And they lose contact with each other, which is called subluxation. And this causes degenerative joint disease or osteoarthritis. And that leads to the symptoms, the pain, etc. There's like a calcified buildup that'll happen. It's kind of gross to look at in pictures, but it's very, very characteristic. Femoral head and neck excision is usually reserved for small patients. Triple pelvic osteotomy is used for immature dogs that have minimal to no arthritic changes of the hips. And then total hip replacement is a salvage procedure that is used in large breed dogs. These are some of the surgeries that are used for hip dysplasia. There's also plenty of medications that temporarily relieve pain, but obviously you have to come get them over and over again. Okay, then the stifle, very important joint. There's plenty of ligaments and joints apparently in here. For example, joints between the patella, which is its own bone, and the tibia. So feel your kneecap, that is your patella. The tibia is the bone below that. The patella is what is called a sesamoid bone. It kind of just floats around near the spot. And you've actually got two other sesamoid bones behind the tibia in your leg pit, if you will. The other side of your kneecap, opposite of your kneecap, those are called fabella, or fabellae, plural, I guess. Okay, there is the femorotibial joint, where the femur, femoropatellar and femorotibial. Oh, okay, yeah, sorry, I was wrong. It's all on your femur. It is not on your tibia. Your patella is on your femur. And that makes sense because remember, the femur is your thigh bone. Okay. So femoropatellar joint, that's where the femur meets the patella. And then there is a femorotibial joint where the femur meets the tibia. The tibia is like your shin bone. Okay. There's also a patellar ligament, spelled like patellar, you know. Yeah, there's a lot of joints in the knee. There's also menisci. They're like C-shaped meniscal cartilages that support the bone. It's kind of like a cushion. There's more ligaments, medial and lateral, collateral ligaments. Wow. There's also cranial and caudal cruciate ligaments. If you've ever heard of a CCL repair, or if you've ever heard of a human getting an ACL tear, that is the animal equivalent, the ACL is the human equivalent of the CCL in animals. Because it's all just named differently a little bit, because the animals, you've got to remember, animals are on all fours, and so their head is horizontally facing, and yet it's like facing up, while our heads are vertically, our bodies are vertically oriented, and their bodies are horizontally oriented. Cranial, caudal, cruciate ligaments. And if you rupture the CCL, which is the most common one to rupture, the tibia moves in characteristic fashion. There's like a drawer sign, drawer, like, you know, the thing you put stuff in, I guess, on the table. It's called the cranial drawer sign. What that means is you can draw the tibia caudally. You can like move it caudally. And it's not supposed to do that. It doesn't normally do that if the ligament is fine. Again, there's menisci, and there's also a transverse ligament, and then there's a meniscofemoral ligament. Okay, and that's all for this live. I'm going to make another one here in a couple minutes. Thanks for watching.